Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 245 of our pharmacotherapy series, which majors in infectious diarrhea. The first question reads, SAT is an otherwise healthy 23-year-old college student, who presents to the Student Health Center with an acute gastrointestinal illness after eating at the school cafeteria. SAT recalled eating the salad and the cream-filled pastries, and stated that within 3 hours she felt nauseous and began vomiting. So my question to you is, why is SAT's history of present illness and clinical presentation consistent with food poisoning caused by Staphylococcus aureus or Bacillus cereus with short incubation? Foodborne illnesses are often grouped by the usual incubation period into less than 6 hours, 8 to 16 hours, and greater than 16 hours. The rapid onset, that is within 6 hours, of SAT's intestinal symptoms after eating suggests the illness is caused by preformed toxins, such as those produced by Staphylococcus aureus or Bacillus cereus, which cause short incubation disease, and cause the emetic syndrome. Diarrhea and abdominal cramps may also occur. Although cooking kills the toxin-producing bacteria, it does not destroy toxin that has already been produced. Foods implicated in staphylococcal food poisoning include salads, cream-filled pastries, and meats, whereas foods implicated in Bacillus cereus food poisoning include fried rice, dried foods, and dairy products. The next question reads, CAP is also an otherwise healthy 23-year-old college student presenting to the same student health center as SAT in the previous case with an acute gastrointestinal illness. CAP recalled having lunch at the cafeteria, selecting a fish and poultry meal. Approximately 10 hours after eating she experienced diarrhea and abdominal cramps. Why is CAP's history of present illness and clinical presentation consistent with food poisoning caused by Clostridium perfringens or Bacillus cereus, that is long incubation disease? Should empiric antibiotics be prescribed to either of these students? In contrast to SAT, the longer incubation period before the onset of symptoms is consistent with illness caused by Clostridium perfringens or Bacillus cereus, that is long incubation disease, manifesting as a diarrheal syndrome. These bacteria are associated with an incubation period of 8 to 16 hours and symptoms of diarrhea and abdominal cramps. Vomiting is not a prominent symptom in these illnesses. Clostridium perfringens or Bacillus cereus, which cause long incubation disease, produce heat-labile toxins after the ingestion of contaminated foods, explaining the longer incubation period compared with illness caused by the ingestion of preformed toxins. Foods implicated in Clostridium perfringens food poisoning include improperly stored beef, fish, poultry dishes, pasta salads, and dairy products, whereas foods implicated in long incubation Bacillus cereus food poisoning include meats, vanilla sauce, cream-filled baked goods, and salads. Foodborne illnesses caused by these toxin-producing bacteria usually resolve within 24 hours, therefore, antibiotic therapy is not indicated for either student. The next question reads, CCK is a 35-year-old, previously healthy man presenting to his physician with complaints of 15 days of watery diarrhea and a 5-pound weight loss. He is concerned that his illness is related to the announcement by the Ministry of Health notifying the community of an outbreak of cryptosporidiosis from contaminated water supplies. Why is CCK's history of present illness and clinical presentation consistent with cryptosporidiosis? Should antiprotozoal agents be prescribed to treat cryptosporidiosis in otherwise healthy persons such as CCK? A key finding from CCK's history is his exposure to water supplies known to be contaminated with Cryptosporidium oocysts. Other modes of spreading cryptosporidiosis include animal contact, that is with cattle and sheep, and person-to-person contact. CCK is presenting with persistent diarrhea, i.e., diarrhea lasting longer than 14 days. Common microbial causes of persistent watery diarrhea include parasites, such as Isospora belli, Microsporidia, Giardia lamblia, and Cryptosporidium parvum. The spectrum of infection with Cryptosporidium parvum ranges from asymptomatic carriage to a persistent, non-inflammatory diarrheal illness. Vomiting, abdominal cramps, weight loss, and fever may also occur. Immunocompetent patients like CCK can generally expect a self-limiting illness lasting approximately 2 weeks. In contrast, in immunocompromised patients cryptosporidiosis can be a chronic, debilitating, diarrheal illness associated with malnutrition, increased mortality, and in children, long-term cognitive impairment. We will now discuss its treatment. For immunocompetent hosts with cryptosporidiosis, other than replacement of fluids and electrolytes, no specific therapy directed at the organism is generally required. However, nitazoxanide is an FDA-approved treatment for diarrhea caused by Cryptosporidium parvum. A randomized, double-blind, placebo-controlled trial in immunocompetent adults and children found that diarrhea resolved in 80% of those treated with nitazoxanide versus 41% of patients given placebo. Oocyst shedding was also significantly reduced in the treatment group. Diarrhea generally resolved within 3 to 4 days of starting treatment. Nitazoxanide 500 mg orally twice daily for 3 to 14 days is recommended for the treatment of cryptosporidiosis. In contrast, in immunocompromised persons, a meta-analysis of treatments for cryptosporidiosis found no evidence to support the role of chemotherapy. These findings are consistent with randomized trials concluding that neither a short, 3-day course of nitazoxanide nor a more intensive regimen of nitazoxanide dosed at 200 to 400 mg orally twice daily for 28 days provided any benefit to HIV-positive children. For HIV-infected persons, reconstitution of the immune system with effective antiretroviral therapies is the mainstay of treatment for cryptosporidiosis. The next question reads, an outbreak of Salmonella gastroenteritis being investigated by the Department of Public Health has traced the source of the outbreak to Restaurant A, specifically the popular turkey dinner special. Anticipating that infected diners with specific clinical syndromes associated with Salmonella infection will benefit from antimicrobial treatment, and that antimicrobial-resistant Salmonella species are increasingly problematic, the Department of Health has asked you to address the following question of what antimicrobials are available for the treatment of non-typhoidal salmonellosis. Let's consider chloramphenicol, trimethoprim sulfamethoxazole and ampicillin. Until the late 1980s, standard treatments for non-typhoidal salmonella were chloramphenicol, TMP, SMX, or ampicillin. By the early 1990s, widespread multidrug resistance defined as simultaneous resistance to ampicillin, chloramphenicol, streptomycin, tetracyclines, and sulfonamides precluded their use as empiric therapies for the treatment of salmonellosis. Depending on the geographic area, rates of MDR salmonella species are as high as 80% in East Asia and Southern Europe and 30% to 40% in the United States. As MDR salmonella species remained susceptible to the fluoroquinolones, these antimicrobials became the agents of choice for the treatment of salmonellosis. Interestingly, since the early 2000s there has been a decline in the prevalence of MDR non-typhoidal salmonella in some areas of the world. Next we will discuss fluoroquinolones. With the advent of MDR non-typhoidal salmonella, fluoroquinolones were widely prescribed for the empiric treatment of non-typhoidal salmonellosis. During the 1990s, suboptimal clinical responses following treatment with fluoroquinolones were noted when isolates were resistant to nalidixic acid. Both nalidixic acid and the fluoroquinolones are related compounds belonging to the quinolone family of antimicrobials. As these isolates also displayed elevated ciprofloxacin MICs compared to nalidixic acid-susceptible strains, i.e., 0.12 to 1 microgram per milliliter versus equal to or below 0.06 microgram per milliliter, they were referred to as having decreased ciprofloxacin susceptibility, abbreviated as DCS. Consequently, nalidixic acid resistance became a surrogate marker for isolates with decreased ciprofloxacin susceptibility, for which ciprofloxacin was not an optimal antimicrobial choice. In subsequent years, additional fluoroquinolone resistance mechanisms in Salmonella species emerged which were not detected by nalidixic acid screening, i.e., isolates were nalidixic acid susceptible but had elevated ciprofloxacin MICs. Thus, nalidixic acid resistance was no longer a reliable surrogate marker to detect Salmonella with decreased ciprofloxacin susceptibility. Consequently, in 2012 the Clinical Laboratory Standards Institute, abbreviated as CLSI, lowered for Salmonella species the breakpoint for susceptibility to ciprofloxacin from below 1 to below 0.06 microgram per milliliter, a change which would reliably detect Salmonella with decreased ciprofloxacin susceptibility. The CLSI also recognized that not all laboratories, e.g., resource-limited settings, would be able to institute these new ciprofloxacin breakpoints, and because nalidixic acid-susceptible isolates with concurrent decreased susceptibility to ciprofloxacin are still uncommon, CLSI allowed for the continued use of nalidixic acid screening, though prescribers should be made aware of its limitations as a marker for isolates with decreased ciprofloxacin susceptibility. Currently, nalidixic acid-resistant non-typhoidal salmonella are prevalent in Asia and increasingly more common in the United States, reportedly 0.4% in 1996 and 2.3% in 2003. Antimicrobial treatment options for nalidixic acid-resistant salmonella include azithromycin and selected third-generation cephalosporins. Next we will look at beta-lactams. Non-typhoidal salmonella resistance to ceftriaxone is currently uncommon, but it has been reported worldwide, including in Africa, Europe, Asia, the Philippines, and the United States. Some isolates are also simultaneously resistant to fluoroquinolones. Carbapenems have been successfully used for the treatment of invasive infection caused by ceftriaxone and ciprofloxacin-resistant Salmonella enterica serotype choleraesus, though carbapenem-resistant Salmonella have also been reported. Next we will discuss azithromycin. Azithromycin displays good in vitro activity against non-typhoidal Salmonella enterica and is a recommended treatment for non-typhoidal salmonellosis requiring antimicrobial treatment, including the treatment of nalidixic acid-resistant isolates. The next question reads, BOB, a 35-year-old, otherwise healthy man presents with a one-day history of fever, abdominal pain, nausea, vomiting, and non-bloody stools. BOB has no significant medical history. Physical examination is significant for a non-ill appearing, febrile male. His presumptive diagnosis is mild, uncomplicated non-typhoidal Salmonella gastroenteritis. So my question to you is, should he receive antimicrobial therapy? Like BOB, within 6 to 72 hours of ingesting contaminated foods, patients begin experiencing the clinical manifestations of Salmonella gastroenteritis, including acute onset of fever, diarrhea, and abdominal cramping. In more severe illness, bloody diarrhea and dehydration may occur. In otherwise healthy individuals with uncomplicated non-typhoidal Salmonella gastroenteritis, antimicrobials are not recommended as salmonellosis is typically a self-limiting illness lasting for 2 to 5 days. Antimicrobials do not reduce the duration or severity of illness and may be harmful by placing patients at risk for adverse drug reactions, prolonging the asymptomatic carriage of Salmonella, and promoting the emergence of antimicrobial-resistant bacteria. Most individuals like BOB will only require replacement of lost fluids and electrolytes. The next question reads, 3 weeks after resolution of BOB's episode of Salmonella gastroenteritis, he continues to excrete Salmonella bacteria from his stool, despite remaining asymptomatic. So my question to you is, should antimicrobials be prescribed to eliminate BOB's intestinal carriage of non-typhoidal Salmonella? Antimicrobials should not be prescribed to eliminate asymptomatic intestinal carriage of non-typhoidal Salmonella. A randomized, double-blind trial in healthy, asymptomatic adults from areas where non-typhoidal Salmonella infection is endemic found that neither norfloxacin nor azithromycin were better than placebo in eradicating intestinal carriage of Salmonella species. The median duration of fecal shedding of non-typhoidal Salmonella is about 1 month in adults and 7 weeks in children younger than 5 years of age. The next question reads, WMS, a 50-year-old male with a past medical history significant for a recently diagnosed malignancy, presents with a one-day history of fever, severe abdominal pain, nausea, vomiting, and non-bloody stools. 1 day prior to the onset of these symptoms, he ate cream-filled pastries from a bakery that has since been closed by the Department of Health because of its association with an ongoing outbreak of Salmonella gastroenteritis. So my question to you is, should antimicrobials be prescribed for his presumed diagnosis of Salmonella gastroenteritis, and if so, what would you recommend? Antimicrobials are indicated for patients at risk for developing extraintestinal Salmonella infections such as persons with malignancy, like WMS, diabetes mellitus, rheumatologic disorders, HIV infection, persons receiving immunosuppressive therapies, very young age, low gastric pH e.g., as in infancy, pernicious anemia, or medication-induced, severe infection, and persons older than 50 years of age who may have atherosclerotic lesions which could become hematogenously infected. Overall, less than 5% of patients with non-typhoidal Salmonella gastroenteritis become bacteremic, though infection with some serotypes, e.g., Salmonella choleraesus and Salmonella Dublin, are more likely to cause bloodstream infection. Once in the bloodstream, extraintestinal complications include osteomyelitis, septic arthritis, meningitis, or infectious endarteritis. Lastly, antimicrobials have been used when rapid interruption of fecal excretion of organisms is needed to control outbreaks of salmonellosis in institutionalized persons. For patients at risk for extraintestinal infection or with severe diarrhea, antimicrobial options include an oral fluoroquinolone, e.g., levofloxacin 500 mg once daily for 7 to 10 days, azithromycin 500 mg once daily for 7 days, or parenteral ceftriaxone 1 to 2 grams daily for 7 to 10 days. 14 days is recommended for patients with immunosuppression. For HIV-infected persons with a CD4 equal to or above 200 cells per microliter, the recommended duration of therapy for gastroenteritis without bacteremia is 7 to 14 days, and for patients with a CD4. The next question reads, BTN, an ill-appearing, 70-year-old man with a history significant for the same cream-filled pastries as WMS in the previous case, who is hospitalized for severe abdominal pain, bloody diarrhea, new-onset right hip pain, high fever, and low blood pressure. His past surgical history is significant for a right hip prosthesis. My question to you is, would BTN benefit from antibiotic therapy, and if so, what would you recommend? BTN is presenting with signs and symptoms of Salmonella gastroenteritis, bacteremia, such as fever, and low blood pressure, and possible localized infection of his right hip prosthesis, that is a new-onset hip pain. Treatment of Salmonella bacteremia without localized infection is generally successful after 10 to 14 days of antimicrobial therapy. For HIV-infected persons, a longer course of therapy, lasting 2 to 6 weeks, is recommended. If infection of BTN's hip prosthesis is confirmed, surgery may be required to cure his infection. Recommended treatment durations for extraintestinal non-typhoidal salmonellosis are available. Considering the antimicrobial resistance patterns from where the Salmonella infection was acquired, e.g., travel history, prior antimicrobial therapy, and site of infection, until susceptibilities are available, empiric therapy options include selected IV third-generation cephalosporins, e.g., ceftriaxone 1 gram IV every 24 hours, cefotaxime 1 gram IV every 8 hours, an IV or oral fluoroquinolone, e.g., ciprofloxacin 400 mg IV every 12 hours, ciprofloxacin 500 to 750 mg orally every 12 hours, levofloxacin 750 mg IV or orally every 24 hour, or the combination of a third-generation cephalosporin with a fluoroquinolone. For bacteremic patients, some experts prefer the IV route of administration, particularly until the patient has stabilized, while other experts recommend either the IV or oral route of administration. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it, and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support, and kind collaboration. We look forward to interacting with you in the next video, which will be part 246.